Continuing education credits for physicians and other healthcare professionals is provided by VCU Healthcare Continuing Education. Check out cribsiders.vcuhealth.org for more information.
The Cribsiders podcast is for entertainment, education, and informational purposes only. The views and statements expressed on this podcast are solely those of the host.
Welcome back to the Cribsiders.
Whoa, hey.
I'm Justin Burt, joined tonight by Dr. Chris Chumanchu and wonderful longtime producer Dr. Jess Kelly. Jess, how's it going?
It's going great. Hey, guys.
So excited to have you. We had a great episode tonight with Dr. Lauren Beslow to discuss cerebral venous thrombosis. But before we talk about head clots, hey, Chris, can you tell us about the show?
Yes, we are the Pediatric Medicine Podcast. We interview leading experts in the fields to bring you clinical pearls, practice-changing knowledge, and answer lingering questions about core topics in pediatric medicine.
Awesome. Tonight we have a fantastic conversation with our guest, Dr. Lauren Beslow, who is an assistant professor of neurology and pediatrics at the Perelman School of Medicine at the University of Pennsylvania, and an attending physician in the Division of Neurology at Children's Hospital of Philadelphia. Her areas of expertise include pediatric stroke, hereditary hemorrhagic telangiectasia, and the neurovascular effects of sickle cell disease. She teaches us about red flags and headaches, the best types of neuroimaging, how to search for an underlying cause, and the variations in treatment once a cerebral sinus venous thrombosis is found.
All right, folks, you're going to enjoy this. You better buckle up because we're about to break through some serious blockages in understanding.
Oh.
That was ChatGPT.
Dr. Beslow, welcome to the show. Thanks for joining us on the Cribsiders.
You're welcome. It's a pleasure to be here.
We are excited to have you. We're excited to talk about the topic, but before we dive into some content, can we learn a little bit about you? Maybe give a one-liner introduction about things that you're, a little bit about you, but maybe also something that you're interested in outside of medicine?
Certainly. So I am a child neurologist who specializes in stroke and neurovascular diseases, and I'm also the co-director of CHOP's Pediatric Hereditary Hemorrhagic Telangiectasia, or HHT program, which is part of our Penn Center of Excellence. And outside of the hospital, I think I definitely spend the most time at various soccer fields with my son and going to Philadelphia Union games. Dope.
Rhode Island just got a football club very recently, which is very exciting. We're a new expansion team. It's great. We're not very good. Your title, though, has got to be a mouthful in the email signature. That's got to, for spelling errors, high risk of getting a little red underline and having to right click.
I just changed it, so I'll send an email after and you can check for me.
I'll struggle with this, but you're much smarter than me, so you're probably fine.
Jess, you want to go first?
Yeah, I guess I love hearing what your favorite failure is. Kind of what did you learn from it?
I think it's not a specific situation I remember, but just certain patient encounters where you're explaining something. I think this most typically happens in the ICUs, and the way you're explaining doesn't resonate with the family, or you take a misstep and have to rethink how you are explaining a situation or a treatment and backpedal a little bit. So that type of situation is always a little jarring at the time, but also a challenge because you want to recover and figure out how to make what you need to get across understandable. And different families certainly understand processes in different ways, and it's really important to kind of in real time be able to figure out what your error was in explaining something and changing it in real time. And that is always a challenge, to figure out a mistake in real time and make a change in real time. But it's also something that I like a lot about being in the ICUs as a consultant neurologist.
Yeah, I appreciate it. I mean, I think it's good to normalize. There have been times where I feel like I've gone in very confidently, like I'm going to explain this. I know this like the back of my hand, and then you mistake, or you try to be clever and cute and use a metaphor, and it's like, okay, no, it's not It's not quite like a car. Okay, the metaphor is falling apart slowly. And I think it's tough sometimes, but I love that question because I think it very much normalizes what a lot of people at all levels are part of the kind of the daily routine of, like, sometimes we make mistakes and you keep going and you fix them, and definitely done a lot of bad paddling in my day.
I think we all have.
Me too. All right, I'm going to change it up just a little bit. I'm going to ask you, is there something that our listeners should check out that you've enjoyed recently, like a book, a song, an album, a movie, or a TV show? What has given you joy recently that everyone else should check out?
I think I've spent almost all my time on soccer fields, but I recently had a great trip with my son and a friend who's a surgeon and her son to Denmark, and it was a beautiful country with a lot of history and excellent food and the original Legoland, and that was just a super fun break from medicine and to be with family and friends. So I definitely recommend it as a great trip.
Dope.
That's a good one.
Nice.
Sounds amazing.
That is good. My media, I had a pick of the week, Chris, real quick, the media consumption. I've started following Elmo on Twitter, which seems ridiculous, but, like, highly recommend everyone to follow Elmo on Twitter, and that it's, like, a very nice kind of break from some of the other
you know what? I follow him too. You know, sometimes he just asks how people are doing, and then people respond, and then he's like, everything will be okay, and he'll give good advice. Like, I love Elmo on Twitter. He's agree.
Great. Elmo on Twitter. It's good.
I have to remember my Twitter password so I can follow him.
I feel like we've lost a lot of Twitter followers in the days, which is reasonable and fair.
It's like in the vortex of all the passwords.
Yeah, fair.
Hey, Cribsiders listeners, let's talk some more about Freed. Freed is an AI scribe that listens, transcribes, and writes medical documentation for you. So here's the backstory. Gabby, a family medicine physician, and Erez, a computer engineer, came up with Freed, a solution that could help alleviate the daily burden of overworked clinicians everywhere. And for Erez, selfishly, it could mean that he would spend more time with Gabby, who was spending nights, weekends, and holidays updating medical documentation. So what does Freed do? Freed turns clinicians' daily workflow into accurate documentation instantly. There's no training time, no onboarding, no extra mental burden. All the magic happens in just a few clicks, so clinicians can spend less energy on charting and more time on what they do best. Today, more than 4,000 clinicians and their spouses have fallen in love with Freed. So Freed is this AI scribe that makes charting go away, doing your soap notes for you. It is HIPAA compliant, takes 30 seconds to learn, and costs only $99 per month. But you can try Freed for free right now by going to freed.ai. That's freed.ai. And listeners of Cribsiders can use code CRIB50 for $50 off their first month.
All right, let's dive into some content. Jess, you wanna get started?
So I will start off reading our case. We have a 7-year-old female who has no past medical history who's presenting with a 3-day history of headache. She reports nausea as well as 2 episodes of vomiting and is complaining of double vision. She recently completed a course of amoxicillin for an ear infection. She is afebrile with normal vital signs. Her neurological exam is notable for normal strength sensation, cranial nerves, and coordination. So I think here it'd be important to kind of break this down for our listeners. So can you explain to us what exactly is a cerebral sinus venous thrombosis?
So a cerebral sinovenous thrombosis, or CSVT, occurs when a blood clot forms in the brain's venous sinuses, or the large veins that drain the brain. This prevents blood flow from draining out of the brain and causes an increase in pressure. As a result, blood cells may break and leak blood into brain tissues, forming a hemorrhage, and venous ischemia can also occur. But in some cases, there is just blood clot, which is still an important problem, but that can occur without hemorrhage or ischemia.
So we all know this is a podcast about sinus venous thrombosis. And knowing that cerebral venous thrombosis really needs to require a high level of clinical suspicion, are there any red flags hearing this history that would make you more worried for it?
I think, and of course, it's the bias of being a pediatric vascular neurologist. So I see the patients when they're already diagnosed or almost diagnosed. But the headache in the setting of the recent otitis is a red flag for me, or something that would make me think of this diagnosis. And we probably are diagnosing more sinovenous thrombosis or CSVT in the setting of otitis and mastoiditis because we now know to look for it, and the ENT surgeons know to look for it. So we do see this a fair amount. It's one of our most common causes that we see.
And one of the things that I think of as red flag symptoms for headaches are often things like maybe vision changes or waking up from night. And one of the things I saw is like the double vision. Makes me start thinking of like looking for imaging. Is this one of the things that we're looking for when we think of those red flag headache symptoms, or are there other things that would pinpoint to, this is a complicated headache that is more worrisome. This is possible venous thrombosis.
So the double vision, I'm sorry, I somehow missed that in the case. The double vision is an exam. It could be an exam finding, but it's also the complaint that should always give pause. And you have to, children saying double vision, you have to kind of parse out what they mean, and they might have double vision and say blurry vision. They may not report it, but just look uncomfortable when looking to the side. So you have to pick up on the examination. But double vision can be a non-localizing symptom with 6 nerve palsies when there's increased intracranial pressure. Also the vomiting, that's not really specific because a lot of migraineurs also have emesis, but this is a little bit different. This is a new headache, and any new headache too that doesn't resolve and is lasting several days is another sort of red flag. It's like the Becky Icord bag of red flags for headaches, unremitting headaches, especially new headaches that are out of character for the child and that are not improving should always prompt more evaluation and thought.
Do you have any tips to like further discern the blurry vision? Because I agree, sometimes it can be really hard with the younger kids. Are you having them get a visual acuity? Are you trying to have them cover one eye and then the other? Like, what do you do there?
So the acuity is different from the double vision, but you have to sort of check both because, of course, if a child has papilledema, they also could have decreased visual acuity. So you want to test the extraocular movements, and you have the child hold the head still. And sometimes you might have to help the child by putting a hand on the head and having the child either follow your finger or a toy if it's a very young child. And you see if they are able to bury the sclera on lateral gaze in each direction. And some people don't at baseline, so that can be hard to parse out. But if the child's actually complaining of double vision, then they'll say, it's double. In little kids, they may try to start turning their head because they're seeing double and it's uncomfortable. So they'll start to try to turn the whole head. In terms of visual acuity, you can do, for example, a near a card, and you have to look at what card you have. Does it say it's a 14-inch card and hold it, approximately the distance that it's supposed to be? And you want to test each eye separately. And for littler kids who may not know letters and numbers and shapes yet, which are the typical items on the visual acuity cards, you can use things like finger puppets. So you put a puppet in the fields in one eye, and then you have one coming from the other direction from the lateral aspect, and the child should reorient and look at what's new coming into the vision. And if they persistently aren't looking, then there might be an acuity problem.
The finger puppet acuity exam, I like that. I haven't tried, but maybe now I will. Yeah.
I had more finger puppets before the pandemic, but they're usually made of cloth, so they're harder to clean.
Fair enough. COVID casualty. I want to go back to one of the things you first kind of identified as the acute otitis as being a risk factor. And I was wondering if you could talk about, are there other predisposing risk factors that are associated with the venous thrombosis, or other things that might put someone at risk for having a venous thrombosis?
So there are multiple risk factors, and a lot of them are very common problems in children. So dehydration, and most dehydrated children do not have a sinovenous thrombosis. This is a common precipitating factor in neonates and babies, but it also can happen in older children. Head and neck infections are an enormous source of risk factors, and it can be in the setting of meningitis, but it also could be less severe infections like just a simple or a more complicated otitis or a mastoiditis, in other intracranial infections. And then there are prothrombotic states, and some of them are inherited. And sometimes the thrombosis is the first sign or symptom, I suppose, of this process. So we've had kids who have an antithrombin 3 deficiency whose first presenting problem is a sinovenous thrombosis, and they haven't had any of these other risk factors. There are acquired prothrombotic states. So in the cardiac unit, kids who have high output chylothoraces with chest tubes, this could be a precipitating factor, or protein losing enteropathy. In our patients with leukemia who've had asparaginase, kids with nephrotic syndrome may be losing protein, so that is another population. Iron deficiency anemia, and if there's very severe anemia, there can be thrombosis. Inflammatory bowel disease, especially in the midst of a significant flare, but not always in the midst of significant flare. And then there are rheumatological diseases like Behçet's. Sickle cell disease, we think of arterial ischemic stroke and steno-occlusive arteriopathies, but kids can also have sinovenous thrombosis. Pregnancy, and we see that in some of our teens and in, of course, young women, but pregnancy is a risk factor. Certain medications like oral contraceptive pills with estrogen, those are a lot of the main factors. We've also seen them post-traumatic. So we've had kids who have a direct trauma over the superior sagittal sinus or who have other head trauma, who develop because of compression and slow flow thromboses.
One question I have is, I've heard, is it possible, especially like in neonates, for like transplacental transfer of like maternal antiphospholipids? I heard something like that before.
Antiphospholipids, yes, that's usually not a risk. That's in most cases in our patient population, not a major risk factor for sinovenous thrombosis. But when we see a lot of arterial clots, and we don't see any of this very often, I should point out, but that is a risk factor for neonatal stroke. It's not one that we see very often with the transfer of antibodies, but it is a potential risk factor.
Can I ask some of the risk factors? Two questions. Sorry to do the double-barreled question, but I think they're related in that a lot of those underlying conditions, whether it's iron deficiency or high volume chylothorax, is there a clear physiology or pathophysiology of what's causing the clot? And is it the same as what would put you in kind of a prothrombotic state in general? So you talked about pregnancy, you're just at risk for clots in general. But are there specific things that would make you more susceptible to a cerebral venous clot as opposed to a DVT or a PE?
So I don't know the answer to why a cerebral clot in a lot of instances. There's some kids whose anatomy they might have. People often have asymmetric transverse sinuses, for example, but there's not really evidence that would be the cause of having this type of clot versus another clot. And I have at least one patient. We don't know why he had a clot, but he had a sinovenous thrombosis, and he was treated, and he went off, and then he came back with a PE. So it was, he ended up with clots in multiple venous systems. So why one first? I don't know. The pathophysiology, I don't think we fully understand it. In some of these states, we think we're losing some of these proteins, like in the nephrotic syndrome or with PEG asparaginase, that is, some of the proteins may be low. But I've had kids with nephrotic syndrome and we measure these proteins and they're actually not low, and we're thinking, oh, they're losing these factors like protein C and protein S, et cetera. And then the levels end up being normal. So I don't think we fully understand all of this. Some of it may have to do with the inflammatory state as well. And then of course, dehydration, you're sort of hemoconcentrated and there could be slower flow. And if you think about the head and neck infections, that's again inflammatory. And in some cases, there could be direct compression. But in a lot of cases, there's not.
So that, it sounds like, is probably the proposed mechanism of, say, an acute otitis. You're having inflammation in that area. There's small vessels, and that ultimately leads to a clot in the head.
Well, these vessels are typically large. So we're talking about the transverse sinus. When we're talking about otitis media and mastoiditis, those are much larger vessels. But there's inflammation. There can often be some fluid and actual probable compression. And the treatment, I think we'll talk about treatment eventually, but that often is a washout, and so a surgical mastoidectomy and washout, antibiotics. So they're addressing the inflammation more directly. And that is even more important than the anticoagulation probably for some of those kids.
Can I ask for clarification on some of the terms that we've been using? Can you help me with the exact definition of, so we've said cerebral venous sinus thrombosis, but I think we've also, a couple of times we might have said cerebral venous thrombosis. Like, what exactly is the difference? I think I've heard it used interchangeably, but also I think there probably is a difference in terms of management between the two. Can you explain a little bit about that too?
I think I also used the term head clot once. So
yeah, I think we're mostly talking about the same thing. So people will say cerebral sinus venous thrombosis or sino-venous thrombosis or CVT, cerebral venous thrombosis. And that can sometimes include the thrombosis of some of the smaller veins, the cortical veins or medullary veins as well. So I usually just call it cerebral sino-venous thrombosis and use CSVT, but I think we're using everything interchangeably.
And can you remind us a little bit about the anatomy of where these clots appear?
So the venous system, so there are deep venous sinuses, or these are the great sinuses in the brain. So the dural venous sinuses, we're talking about superior and inferior sagittal sinuses, straight sinus and torcula, transverse sinuses, sigmoid sinuses, and some of these deeper veins, and then some of these tinier veins like the cortical veins, which don't really count, and medullary veins too don't really count as CSVT, but they are venous clots. And we sometimes think of them a little bit differently, and they can happen together. So a lot of kids with a true dural sinus venous, cerebral sinovenous thrombosis will also maybe have a cortical vein clotted as well. But you can see them in isolation.
I'd love to hear a little bit more. I think you've talked about, the physical exam, but what kinds of things are you particularly looking for if you're considering this higher up on your differential? So we know we're making sure extraocular movements are intact. We're maybe looking for a head tilt to compensate for double vision. But are there other things that you think are helpful at the bedside?
So yes. So it's first important to note that a lot of kids with sinovenous thrombosis may have completely normal examinations, which in general is a good thing, but the examination may not give you all the clues to the diagnosis. And then you want to look at some general parts of the examination, like, for example, meningismus for kids who might have meningitis. Specifically to sinovenous thrombosis, we might look for papilledema and visual loss, which is less common. And then there can be the 6 nerve palsies we already discussed from increased intracranial pressure. So those are long nerves and there's pressure on them. And then the lateral eye movements are impaired, and that could be bilateral. It could be asymmetric. It can be unilateral as well. And then some children with sinovenous thrombosis may have hemorrhage or venous ischemia or venous hemorrhage. So they can also have focal neurological deficits and be difficult to differentiate by examination from someone who has a primary hemorrhage or someone who has an arterial ischemic stroke. And there can also be mental status changes. So that is very important. Very sick kids with sinovenous thrombosis may have mental status changes, coma, and symptoms like that. Also seizures. So any of these seizures is obviously that's not an exam finding, I guess, if they're actively seizing. But these are parts of the presentation and history that can also clue you in.
Would we ever see any scalp changes, like edema or dilated veins or anything, if you could see a scalp? I mean,
theoretically, that we've just had a child. I didn't actually see this child who's developed, and this happens, I think, maybe more on the adult side, who developed dural fistulas, and that I suppose could be palpable, but usually we don't see any scalp changes or changes in the neck unless the child has a neck infection.
And so if I'm a provider who happens to be moonlighting in the pediatric ED when this happens or in the outpatient, and I immediately pick up that there's a red flag symptoms, just had acute otitis, double vision, headache won't go away, emesis, I'm terrified. I at least recognize that this is bad. I immediately will just try to start ordering imaging. And can you help guide, can I just get away with a CT? Do I have to order one of these fancy CTs that has an extra letter at the end? And maybe could you even kind of explain what those extra letters on the end do for me?
Sure. So a non-contrast CT can actually be quite sensitive for sinovenous thrombosis. If you're thinking about it, you might not see all of the extent, but it can be a good clue. There can be some difficult situations, especially in neonates or in polycythemic patients who appear hemoconcentrated, that can be difficult, and sometimes transverse sinus thrombosis on head CT. I've seen those be kind of mixed up with potential subdural hemorrhages, for example. But the most formative imaging is typically an MRI with and without contrast, and we like to add MRV, so that's the MR venogram. But if you can only get one of those, our neuroradiologists typically prefer having that contrast enhanced MRI. The head CT, as I said, has about 80% sensitivity for detecting sinovenous thrombosis, but of course that interpretation can be difficult. And in some kids, due to a variety of factors, you might not be able to get MR-based imaging. So you can get a CT with a CT venogram, and then you'll have more evaluation of the dural sinuses. And that can be paired with CT. We tend to try to get MR-based imaging when possible because there's no radiation involved. But there are times when we just can't get the MR-based imaging for a variety of reasons. And then the CT-based imaging is typically faster. Another benefit of the MRI is we can see the parenchyma of the brain, and we can evaluate a little bit better for hemorrhage or microhemorrhages. And we can, of course, see infections a bit better. And we've already discussed that that's a major risk factor. And sometimes having that additional information on the MRI may help with surgical planning. So those are the main ways. But a good place to start for a lot of places is the non-contrast CT. But there is a push more and more in pediatric centers to try to avoid CT when possible. And so if this is your suspicion and the child is stable, you can get the MRI with and without contrast and MRV.
And that was going to become my question, is that the level of urgency. It sounds like if the patient's hemodynamically stable and you can get an MRI image within several hours, then it might be worthwhile. I feel like the CT is always quick and looking for bleeds. I also imagine if the patient's presenting with the red flag symptoms, we obviously don't know that it's a sinus venous thrombosis, but the MRI obviously should still find some other imaging. So it sounds like if they're stable, there's a move towards going to MRI and not just doing quick CT scans. Is that right?
Often, and it's somewhat center dependent, but you also want to think about a child could deteriorate. This is a life-threatening process. So, stability is reassuring, but, waiting a few hours can be fine. If it's going to be much more than that, you may want to try to start with your head CT and see where that leads.
And there is kind of some new rapid head MRI imaging going around now, right? It's center dependent, but they have some of these. Do those work well in this setting?
Not for this, because you need the contrast enhanced MRI, and those rapid protocols are typically looking for arterial ischemic stroke. And they include the diffusion weighted imaging and the ADC map. So looking for restriction of water diffusion, which happens very acutely in the setting of ischemia. But it's not, these protocols typically don't include the contrast, and they're really meant for hyperacute therapies for arterial stroke. So you definitely probably wouldn't want to get like a rapid protocol brain MRI that's meant for detecting hydrocephalus or detecting an arterial stroke.
Great.
I feel like I'm often in the situation where an MRI is not possible due to needs for sedation for younger patients. In that case, if I do have CAT scan available, would you do CAT scan with venous contrast, or would you just say it's fine, the sensitivity of non-contrast head CT is high enough? Would you have a preference?
I wouldn't rule out sinovenous thrombosis just based on a head CT necessarily, but this is a good time one of the many good times to talk to your neuroradiologists about what your concern is. For example, you can have a CT that is very suspicious or even tells you there is a sinovenous thrombosis, but you don't need to go back for a CTV. You know what you have in a lot of situations, and you can wait for the MRI and make your first sets of treatment decisions based on these. A lot of pediatric hospitals have sort of 24/7 availability of urgent sedation and anesthesia for MRI for stroke diagnosis indications, but not all hospitals have this. So it really varies widely. So I think it's important not to be too prescriptive and say that we must do this. Each patient is different. The acuity can be very different. A comatose patient or a very altered patient or a patient who's just been seizing is a very different patient for the patient you're presenting who's otherwise pretty well appearing and is stable, and the MRI or the imaging is urgent, but it's not hyper emergent. I don't know. I made that up. There's no hyper emergent. Super stat.
Yeah, that is helpful. And so it sounds like you really do start with a non-contrast CT. Like you wouldn't pull the trigger on a CTV immediately. And is the reason because you don't want to obscure other findings that you might be looking for with a similar presentation, or you just don't want to expose the kid to contrast?
It's contrast and it's contrast and it's radiation. So it's worth a discussion there. If it's worth a discussion if you have a really high suspicion and you do not feel that you are going to be able to get an MRI in a reasonable amount of time. It's a great discussion to have with your neuroradiologist, because if for some reason a child just can't get sedated or can't get in the MRI, some kids have actual contraindications to even going into an MRI scan. We see that in the cardiac unit all the time. Having that conversation up front and knowing the suspicion, they can sometimes get the CT. You can have, in some circumstances, a radiologist looking at real time. And if they're suspicious, then they can add that on without having to ship the child and transport the child up and then back down. Which is always, which is more medical power and not that pleasant for the patient.
I think that makes a lot of sense. And to be honest, imaging always confuses me anyway. And so what I love is to talk about labs and lab values. And so for a patient like this, is there any sense in getting lab values? Is a CBC or some clotting factors or D-dimer? Can we rule out a CVT? Should we check their CRP while we're at it? What kind of labs might be helpful in this kid?
We usually get a CBC and coagulation parameters in this type of setting. If we see a sinovenous thrombosis, there's certain settings like we will check D-dimer and fibrinogen. If a D-dimer, if you know there's already clot, will be high. If for some reason the hematologists need this value, we will check it. We sometimes just check it. But for the workup, that's where we do the hypercoagulable studies, and that's to diagnose additional risk factors. Now, there's some situations, if there's just an obvious mastoiditis, we don't always actually do the entire hypercoagulable workup, but in an unprovoked situation, or even in a child who might have a chest tube or IBD or inflammatory bowel disease, we may still send this entire workup because there could be some additional risk factor. And those labs, we wouldn't advocate for sending these up front. This is once you have the diagnosis of a thrombosis, because they're expensive, and we send this for confirmed cases, but we check the antithrombin 3 level, and that level, it's very important to remember to send it before any heparinoid is started. And then the protein C and S levels, factor 8 level, we check homocysteine and lipoprotein a, DRVVT, the beta-2 glycoprotein, IgM and IgG, anticardiolipin, IgG and IgM, and then we also send for factor 5 Leiden variants and prothrombin gene variants. And then there's sometimes some special labs we may send if we suspect that the child has inflammatory bowel disease or celiac disease. We may send labs for those. If there's a thought that the child may have a rheumatological disease, we may have rheumatology consult and send various rheumatological studies. And yes, the CRP and ESR can be high in these, but they don't necessarily guide management. So those may be checked more if there's a thought that there's an infectious process as a trigger.
And with the D-dimer, while I'm trying to figure out who my neuroradiologist is, can I order a D-dimer if it's normal, rule out sinus venous thrombosis, or is a normal D-dimer not a clean slate for this kid?
So when we've checked them, they typically are high, but I think I've had some kids where they're not super high. I think that I don't think that they would. The lab value probably wouldn't be back faster than you can see a head CT. And so I would rather diagnose a process by looking at the place the process is rather than these labs that are really non-specific. Because you could have high D-dimer for other reasons, so you're not going to treat based on that, and you still need the studies.
Are these kids who you're normally getting a lumbar puncture on? Are you checking to see, is there a meningitic trigger? Or do they have a high opening pressure? Or is that something that's ever useful?
It can be useful. Not all children with sinovenous thrombosis have a lumbar puncture. So if there is concern that there's meningitis, we will check. If there's clear elevated intracranial pressure signs like papilledema, and we think that we really need to relieve pressure, we might do it. I would probably, in that kind of scenario, want to see the imaging first to make sure there isn't mass effect from a concomitant hemorrhage or a lot of venous ischemia and edema causing mass effect that could render the LP unsafe. But there can be a role. It's mostly looking for infection and evaluating the intracranial pressure. We assume that the pressure is high in a lot of cases, but we don't always need to measure it.
And do you ever treat that symptomatically? Will these kids get acetazolamide or steroids or anything?
So I have had kids get acetazolamide. That's a great question. If there is a lot of if there's a significant papilledema and vision loss. We also want to be a little bit wary of acetylzolamine's a diuretic, and we want to hydrate, not dehydrate. But we also recognize that the treatments for CSVT sometimes kids kind of miraculously look better even after the first dose of a low molecular weight heparin, but it's not going to the clot isn't going to recanalize immediately in most cases, so that pressure may take some time to go down. So vision loss would be a symptom that would prompt me to at least think about whether an LP and lowering the pressure a little bit would be helpful.
It looks like we sort of transitioned to talking a little bit about treatment. Can you expand a little bit about that? You said something about using low molecular weight heparin. Is that the only type of treatment we do? How long will we treat them for? What are we following after we start?
Sure. So there are a few things we do. So one is hydration, and there's certain populations, cardiac populations, children with sickle cell disease, where, we will say 1.5 times maintenance. That's not always possible. You may not be able to do that to a baby either. But hydration, and at least maintaining adequate hydration, is important. Next, we want to remove any provoking features. So if there's severe iron deficiency anemia, one, hematology needs to be involved, and two, that patient might need a transfusion or iron supplementation. If a teen or other person is on an OCP, an estrogen containing pill, then we want to stop that immediately. There are certain triggers like asparaginase that the child just might need to keep getting, and there may not be an alternative. So we work with the hematologists and oncologists around that, because we've had kids who rethrombose, but we've also successfully gotten kids through more doses without rethrombosis. So those are important things to think about, and not just the main acute treatment. So with infections, treating the infection can be the mainstay of the therapy. So starting the antibiotics, decreasing the inflammation, and then looking for any intracranial infections or infections in the mastoid and sinuses that need to be surgically cleared out, because if that is necessary, that may even be enough. When we talk about anticoagulation, a lot of kids and babies do get anticoagulation, but not everybody. So an area of, I don't want to say it's not really controversial, but there are practice differences, is in the setting of mastoiditis in a well child who may have a non-occlusive clot. There are centers that just do the antibiotics and any surgical treatment that's required. At Children's Hospital of Philadelphia, we have tended in most cases to also use an anticoagulant. For other kids, anticoagulation is typically used. We most often start either a heparin infusion or a low molecular weight heparin like enoxaparin. And we also do this in some babies. The babies, again, it's an area where there are more unknowns. There's adult information that we've extrapolated to kids that even if there is a hemorrhage, in most cases, we should treat with an anticoagulant, because the pathophysiology of the hemorrhage isn't a primary bleed, but it's due to pressure buildup and backup because of the clot. And by not allowing the clot to propagate further, you decrease that risk of hemorrhage expansion. But in babies who have a lot of blood, there's more concern, and they also have the open fontanelle. So that is an area where we consider each case. There's some people who don't anticoagulate at all in babies who have some blood. And there's even a question, I think most people probably anticoagulate babies with CSVT without blood, but not everyone. So there's certainly practice variation there. In terms of the older kids, I think most of them will get anticoagulation. In terms of how long, there are some studies in the hematology literature that indicate that probably some clots could be treated at 6 weeks, but I think you have to, again, think case by case, because those studies aren't necessarily thinking about, in this particular child, what was the clot burden. So if you have a child who has clotted off many of their major sinuses and it's completely occlusive, and you have superior sagittal sinus and transverse sinus, and are they really going to recanalize in 6 weeks? Probably not. So we should probably treat longer. So if you're thinking about a kid with mastoiditis who has a small clot, maybe it's not occlusive, 6 weeks might be quite reasonable to be a time point where you check again, look for recanalization and reassess. What we have tended to do is most often check via usually MRI at 3 months and look for recanalization. And if there is incomplete recanalization, we continue for 6 months. And then in some cases, most cases, stop then, even without reimaging. If there's recanalization at 3 months, then we stop. But there's some kids who continue even once the clot is completely gone. So, for example, a child with antithrombin 3 deficiency, this is really a hematology call, but that my patient who presented that way is on anticoagulation for life. Child with unprovoked Sinus Thrombosis, meaning we didn't figure out why. Probably there was some reason why, but we don't know. And then they're probably at risk for another clot. And there is study, and there are studies in the hematology literature that demonstrate a higher risk for thrombosis recurrence, not necessarily in the head, but other locations with unprovoked clots. So my example of a patient with sinovenous thrombosis who was treated, went away, we stopped it, and came back with a PE. So that's a good example of a kid who benefits from lifelong anticoagulation. So I think it's just really important to think of these as they're all, some of them are variations, some cases are variations on a theme, but there are a lot of nuances and a lot of patient factors that should go into these decisions. And there is evidence in older kids that we can change some over to DOACs at some point, and that is a lot easier than the injections, which most kids tolerate unbelievably well, but still the DOAC is easier. And another treatment is removing the clot, and so thrombectomy. That is rarely done. I think we sometimes don't think about it enough. I feel like we should think about it and discard it rather than not think about it at all. But we usually reserve that for a child who is progressing and getting worse despite anticoagulation. We've done it once in a child who absolutely could not have anticoagulation. But if you perform that kind of procedure with no anticoagulation, the chance that it rethrombosis is, quite high. But having an excellent interventional neuroradiologist or interventional neurosurgeon on the team experienced with pediatric patients is important. And we've gone after the clot just a few times. I just want to go back to the risk factors because I left out one, and that is leukemia itself. This is also rare, but I remember many years ago a boy whose first presentation was APML was a synovenous thrombosis. So we don't see that type of leukemia very commonly in kids, but that's also a risk factor, and it's just not just asparaginase with children with cancer. There are other factors. There's a lot of inflammation, and there are a lot of new medications too. And I don't know them all, but I haven't heard that any is a really significant risk factor for synovenous thrombosis, but important to think about in that population too.
I love it. It almost sounds like when you have the diagnosis, you need to start looking for other things and not just that there might be some underlying condition that you want to make sure you're not missing.
Absolutely. And a lot of the time, the condition is obvious, like the mastoiditis case or a child who's known to have IBD, but it's not always obvious. And that's where the multidisciplinary team of your neuroradiologist and your pediatric neurologist and hematologist and intensivist is really, really helpful, because we can cast a wide net and really think about the child and the general physical examination, the entire history, family history.
So you were saying about, sometimes it is obvious, like we can tell there's like otitis media or whatnot. So when you're counseling, say, a parent about this, and you see there's an obvious provoked reason for this, how do you counsel them about risks in the future? Like, do they have to worry every time their kid gets otitis media in the future?
Oh, that's a really good question. A lot of the kids emerge with ear tubes, which I think helps with that in the younger kids. We've seen a lot more infections too, or infection-related CSVT since the pandemic, or at least it feels that way. I think one of our fellows is doing a project about this, so stay tuned. I'll give it a shout out to Nehali Mehta and her work with Jennifer McGuire, who's a neuroinfectious diseases specialist, and they're looking at this question. But I haven't seen any, I actually have not seen a case related to mastoiditis or otitis who's reclotted. I'm sure there is some child who's had this process in the world, but I haven't personally seen it. But a lot of these kids get a mastoidectomy and a washout and are sort of more protected going forward, the ear tubes. And other processes like meningitis are typically not recurrent. We've had kids with neck infections and neck abscesses that then have local inflammation, clot the IJs, the internal jugular veins, and then also in the head, and those don't usually happen. But you know what? I haven't had one parent ask me like, "Oh no, what happens when my child gets an ear infection next time?" or is this going to happen to my other children? And it is, I suppose, a little funny because often that is a concern about happening again or happening in other kids. And that hasn't been asked, at least to me.
Awesome. Well, I'd love to know where you think in the hospital is the best place to admit these kids. Do you think that these are kids who you can take on your neurology service? Do you think they need to come into the ICU for close neuro checks? What is their ultimate disposition, or does it matter on how extensive the clot burden is?
It's a great question. I think the vast majority of the kids end up in the intensive care unit. Any child with cardiac disease is probably going to go to that unit, and the babies with this are often already in the neonatal unit. But most of the kids coming through end up in the pediatric intensive care unit. And I think, at least at the beginning, that's the right place, because one, we don't know if the child is going to propagate, and we don't want to find a child getting worse in between two Q4 neuro checks. And then there's a risk of hemorrhage. We are often starting anticoagulation, and there is a risk of hemorrhage from the process itself, but also there could be hemorrhagic transformation of a venous infarction, and we want to be prepared for that. So we're usually sending kids to the intensive care unit for at least a day or two until we know that they're stable and we know that they're tolerating the treatment. And then a lot of the kids end up not, the kids with an infection may end up going to the operating room, and then they're post-op. And yes, the surgeons take care of post-op kids all the time on the floor, but this is a little bit different because then we're thinking about anticoagulation post-operatively, and then there's risk of bleeding into the operative site. And we talk to the surgeons about when they're comfortable starting an anticoagulant, if that's the route we're going to go.
I think it'd be great to hear from you if there are any resources or guidelines that we could refer our listeners to if they're interested in learning more about this topic.
Sure. The American Heart Association and American Stroke Association guidelines for the management of pediatric stroke have sections on perinatal and childhood cerebral sinus venous thrombosis. And that was last dated about 5 years ago in 2019. And more recently in 2024, the American Heart Association has put out a scientific statement, Diagnosis and Management of Cerebral Venous Thrombosis, and this is by Saposnik et al. And this paper addresses both adult and has adult sinovenous thrombosis and pediatric sinovenous thrombosis with a separate section dedicated to pediatrics. And in this updated resource, there is some information on the use of DOACs, which was not covered in earlier versions.
Awesome. That's super helpful. Well, I wanted to kind of wrap up our case for everyone. Our patient was found to have a cerebral sinovenous thrombosis on CT scan due to her recent acute otitis media. She was admitted to the hospital. She got antibiotics and was started on enoxaparin for 6 weeks. And she did great.
Yay. We did it. To wrap up, we would love to hear your plugs if you have take-home points for the listeners, anything that you think you want to plug that we should send listeners to check out. What do you want to leave our listeners with?
Yes. So I think that important is that clinicians truly should consider CSVT under certain clinical circumstances. And for pediatricians and ER staff in particular, just knowing that sinovenous thrombosis can complicate otitis media and mastoiditis, as well as dehydration, is really important. And then, as I'm beating the dead horse now, but children who keep coming to the ER for new onset headaches or with a new headache type should be considered for neuroimaging. And that careful history can often uncover risk factors. And prompt diagnosis and treatment can truly influence outcome because, we don't want to have a kid who had no ischemia or no hemorrhage that then develops that because they didn't receive treatment. And then my other plug is really speak to your neuroradiologist about your case because the imaging and the best imaging for the particular child that in this particular hospital setting may be different than another hospital setting or for another child. And they can really protocol a case in a way that it makes the most sense for the age, time of day of presentation, and the institution. And just going back to that idea about the fast MRI, I've certainly had kids who we didn't want to sedate, but we really needed the MRI. And I talked to neuroradiology and they say, well, we'll skip this and make it a little shorter and get what we need. And we'll do it in there's an order they'll acquire sequences, but sometimes they may decide we're going to try to do this next. And obviously they need the pre-contrast sequences before the post-contrast sequences, but they can think with you. So it's really important instead of hemming and hawing and even solely relying on your neurology consultant to speak with the neuroradiologist because they really can help. And if they know what you're looking for and they're worried about, they can help triage and expedite, and they can help read in real time under certain circumstances if needed, add sequences and discuss the case and help you think about it. And occasionally there's something that you might not be thinking about that then prompts you. You might be thinking about, I think this kid had an ear infection, has mastoiditis, and they say, well, we also need to look for an empyema and this and that you haven't thought of yet. So that those discussions are really important. I don't think we talk to our colleagues enough in real time.
I've also found the neuroradiologist to be very helpful in determining if I need to add that letter after the CT with imaging, which is very helpful. Or
they'll call us and be like, you sure you don't want this?
Yeah, you should cancel that ultrasound. You need a brain MRI. This has been really, really wonderful. Thank you so much for taking the time to share your time, your expertise on a topic that I think makes a lot of pediatricians worried, but now they don't have to worry because they can approach all these cases with new confidence. So thank you again for coming on the Cribsiders. Yeah.
One more thing. I mentioned the hematologists a little bit, but I should have mentioned them a lot more. So now the shout out to the hematologists. But hematology for the anticoagulation, they have to be involved. The neurologist may know the dosing, but someone experienced needs to monitor these medications, help with the dosing adjustments, help with the interpretation of the laboratory studies, because they're different in the neonates and younger babies than in older kids. And sometimes we need to repeat those testing. There's some circumstances with the oncology patients where we've had to add treatments like antithrombin 3, I think, infusions, and they are the ones that help with this. So every sinovenous thrombosis case should have right of refusal from the hematologists, and the neurologists should also, vice versa. There are places where hematology really runs these cases, but I think there's an important role for neurology, and any kid with a significant clot burden should have a good neuro-ophthalmology evaluation too for papilledema, because I've certainly had kids who we discovered at outpatient had vision loss, and they didn't have an exam inpatient, so we want to diagnose all of that. So it's really multidisciplinary disease.
That's right. All our friends can come see the patient. I love it. A great way to end supporting the team environment of medicine. Thank you again for joining the show.
Thank you. This was fun.
Thank you so much. This was awesome.
All right. Great to meet you all.
The number you have dialed has been changed. The new number is...
This has been another episode of the Cribsiders.
It's for the kids.
Get show notes and sign up for our weekly knowledge food formula feeds newsletter on our website at www.thecribsiders.com.
We're committed to providing you with high-value, practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts, or contact us at thecribsiders@gmail.com. Special thanks to our producers for this episode, Dr. Jessica Kelly, our wonderful showrunner, Dr. Sam Mazer, and our wonderful social media team on Twitter, Instagram, and Facebook. I've been Justin Lee Burke.
I've been Jess Kelly.
And this has been Chris the Chu Manchu. Thank you and good night. And now, for those who've made it all the way to the end, here is another poem written by AI. Amid the vast and teeming paths that thread the human form, a malady stark and silent, in the deep rivers of the brain is born. Cerebral Sinus Venous Thrombosis, a shadow dire, that grips the youthful streams where blood should merrily conspire. Oh, pediatric plight, where clots like boulders in a stream obstruct the flow of life essence, a child's waking dream. In that intricate network so finely wrought, where thoughts and dreams are silently caught. Doctors whose keen-eyed sentinels with wisdom and with care probe the depths with tools that glance the signs of danger there. With coagulants they fight, a guardian's noble creed, to dissolve the lurking shadows, to free the streams with speed. And so the battle wages with caverns deep, as parents watch and hope through nights devoid of sleep. But behold the might of medicine, with all its learned grace, restores the laughter, the light, the pace. Thus in clinics bright, from bustling cities to tranquil towns, our children shall rise, shall conquer, wearing victory's crowns. And the spirit of hope beams wildly through verses bold and brave. For every child's life we cherish, every child we strive to save. See you guys.